It's a pleasure, really, to be here. And so maybe it's not a Betty Wright day, but let me just share stories about what we do in NPHCDA is very important. They've shared stories here today from the Honorable Minister and the last panel about what's happening within Nigeria, within our communities. I was somewhere in Kebbi State, saw a young girl, 18 years old. She's had 3 children. And we're talking about giving birth. I can tell you the health facility was right across the road. They had nurses, midwives. They had a beautiful labor room. So we're asking, so where, do you give birth? She said, where do I give birth? I give birth here in my room. So I asked her why. He said, it's only a weak woman that will go to a facility, that she's strong. In fact, that when she's in labor, she doesn't want anybody to see her, that she locks herself up and delivers by herself. It's after she's done that she calls her mother-in-law. Another story on the flip side, going to the south, is a personal one. I was in a meeting, I got a call from my cousin. It was like, Chidinma is in the theater. They are sectioning her. In fact, I'm on my way with the baby going to Umuahia. That's about an hour, 45 minutes. So this girl had registered for antenatal at the general hospital, also at a private facility. The doctor saw her 3 days before and knew that it was a case of, a preeclampsia, and they decided to section her. So what he did was pop out the baby, give it to the father, and say, start going to the teaching hospital because they were on strike. So the father grabs the baby, and they get a taxi because he doesn't have a car. And they start heading to Umuahia. So it was on his way that he called me, believing that I can do something. So I said, so where's Chidinma? I said, she's still in the theater, but I'm taking the baby to Umuahia. So I said, wow, okay, teaching hospital, Umuahia. Let me call people I know. So I started calling the people that I know. And then I got the doctor. He said, no worry, we're on strike. We're on strike. I said, but what can you do for me now? He said, there's nothing I can do. See, okay, let me see whether I'll get the nurse. He tried. I said, I can't get the nurse there. And even if you take the baby, they only have 2 incubators, and it's occupied. There's nothing I can do. I said, So I said, call it everybody I know, pediatrician. Okay, where's the private hospital? Whatever. Anyway, he said, let him talk to them. So talking to them, when they got to the gate man said, yeah, you're not going anywhere. We're on strike. You cannot enter. So they took the baby to a private hospital. And said, when you got there, I said, what happened? They said they've not accepted us inside, or they want to check the baby. After a few minutes, I called back. He said, the baby has died. That was her first pregnancy. Yesterday also, after we spoke, a lady came up to me and said, thank God for what people were saying. I had a similar experience. This is an educated person, urban. I said, I lost my baby too. They don't care. The doctor, when she was there, my baby died and he had no emotion. So for us at the primary health care, it is a concern. We don't want any woman to die from any preventable cause. That is our vision. And that is why we know, if we look at our data, we're not doing well. Compare ourselves to maybe Uganda, Ethiopia. We are way back. If we were a business, we will be shut down because we have not done a lot. I've heard today a lot of things that are being said. What does that mean? What does it mean to our NDHS? Nothing. We've moved nowhere. Let's talk about the rural woman. The PHC we're talking about, 70% of our population are at the community level. So we're talking about having one functional PHC in every ward. I saw my sister here, Ugo. I said, Ugo, you should be the one talking here because she's done a lot around that, So what we do. So 70% of our people are in the community. So we have a functional PHC that should have the right minimum package of care. That is 4 midwives, right? Yes, and the others. But where do you get the midwives? We don't have 4 midwives all over the country. We do a categorization for immunization. Okay, these are but all over the country, our indices for RMNCH is poor. In some places you have 4, some you have only 1 midwife. And she's expected to be there from morning till the next day. Is it possible? It's not possible. And that is the issue that we are tackling at NPHCDA. So the NPHCDA, learning from the experiences, learning from what we have learned from polio about having a coordinating platform about having a platform that coordinates what happens at the national, state, LGA, even at the community level. That is what it's about. That is why on the 8th of April, Dr. Faisal, along with other stakeholders who are here, I'm sure some of you were here, declared that state of public health concern. That enough is enough. We have to work together. 200 million opportunities. That is us working for ourselves. For that one woman, I'm not promoting Sterling Bank, but they say one customer. Our one customer is that one woman in our community. So what have we done? We've set up the National Emergency Center. We're looking at the 4 delays. Why would the woman not even go? They talked about it. Even decision to go. In some places, she will not step an inch. There was a place I went to, they said the father, the husband was in Lagos, and the woman is somewhere Bauchi now. So she couldn't go to the hospital because her husband wasn't there. And the person to get permission from was her father-in-law. And the father-in-law was not going to give permission. So that is the situation. So what happens there for the woman to even have that? Okay, what of the money? The money is not there for her to go. So at NPHCDA, as part of the delays, we're looking at the first delay, seeking care. So we have community workers, community-based workers. Over the years, we've had series of, VCMs, IYCM, various community structures doing one thing or the other. But why don't you have this one woman, thinking about Ransom Q2, it talks about one person within the community, selected by the community to deliver care to that one household. And that's the VHW, and that is what we call the Harmonized CHIPS program. They have a curriculum. These women are selected by the Community World Development Committee for their integrity, for the responsibility, and because they are known, they are selected to provide care to that one household. So they have household, in every ward we expect, okay, we should have at least 10 CHIPS, we call the CHIPS agent, providing care. They have a kit providing care to that one household. They enumerate the place, how many households they should be responding to. And when they see the woman, okay, they know she's pregnant or somebody has malaria, she engages them at the household level to provide that minimum care that is required. But she also links this woman to the facility. The CHU is there. There's a CHU that supervises her. So that linkage is there. Even to the community structure, the accountability structure, we talked about the WDC. The WDC also provides that care. So learning from immunization, where for routine immunization, they get the information, the Baba gets, somebody is born, takes it to maybe the village head finally goes to the ward head, and it goes to the facility. We are losing a lot of information. A lot of what's been done here, the data is not there. But the good thing is now we have the CHIPS agent at the community level, what we had before really. We're not reinventing the wheel. Maybe when they made wheels before, they were all round. It's still round. Maybe the tires and things that are done. So that is the same thing. So you have the master, the household register that is kept in the house. Every household has that. So everybody engaged. Even when you come with your program, whatever they are doing, you know that there is this woman, this is the people in the household. Whatever intervention you give is recorded there. And that is also transmitted to the facility. Ultimately, it comes to the national at the PRS so that we know what we are doing. A lot of them at the facility, they don't know what that, falsification, that small thing that is squiggle, instead of 10, they write 200, what it means to our economy, what it means to our facilities. That is one of the things we are doing. Also, the minister talked about the transport system, and somebody talked about Okada. And that is also what, learning from this experience, what we call the mindsets. When the woman gets registered at the antenatal, for her antenatal, or with the CHIPS agent, she gets 2 vouchers. Those 2 vouchers entitles her for a referral, somebody to take her. And it's not the ambulance, because I've learned some of the ambulances, but whoever it is within that structure, within the community, they decide who is responsible for taking any case like this to the hospital. And that voucher means that is reimbursed. So going forward also to the facility, we don't have enough midwives, but we have CHUs. We have other health workers. I was in a place in Kebbi, so they had CHUs. We went there. They didn't have light. And I was asking the woman, so how the CHU was there talking, and the other one was environmental health assistant. So how do you put, you say, I wear this lantern. When you don't have light, we wear this miner's lantern. I said, really? He said, yes. I said, wow, that's wonderful. So let's see the labor room. We went to labor room, paint, as new as when they built it. But the delivery bed was as high as where my grandmother then used to go to. So I knew that nobody had been there. And when we went to the community to find out, this woman also goes to the community to deliver. And she had connected light to her house to take delivery. But the problem was she was charging and she was not treating the women well. And that is what we're talking about, respectful maternal care. But we're talking about respectful maternal care. Are we taught in medical school about that? Are we taught in the nurses? Yeah, the nurses, we went to them and they said, yes, they now have it in the curriculum. But a medical student, the medical, all of us, even in where we are, do we know about, how a woman should be treated? In preparing for this meeting today, I'm sure a lot of things went into it, making sure that we have a quality thing. But for the woman, nothing. It's just, I remember going to the man said, I was talking, the doctor told me, are you a doctor? He walked out on me, just like that. And that happens, and I'm a doctor and I'm educated. Can you imagine that woman, in the village? So for that one woman at NPHCDA, we want that structure coordinating platform that has everybody, all of us, with a responsibility to be there. It's not only about the health. What of education? What of agriculture? Does she know how to feed her child? A girl of 16 was using semovita. She knows it's like cereal, so she mixes it, and she's giving a child. But that's what she knows, and that is a community. Our rural populations, we have a women, the highest level of poverty is there, highest, education infrastructure, and you expect them to have the best care. They don't know that, and we're not giving it to them. And yesterday I was talking to every one of us. I don't know whether you know where your PHCs are in your communities. Yes. So government has built about 4,000, facilities revitalized, and we're shooting for 10,000. It's not a responsibility of only government. It's a responsibility of everybody, the private sector, you and I. When you go to your village, find out if they have one, and let's have a functional PHC that works. Talking about accountability, somebody talked about it also. As part of a functional PHC, we should have a functional ward development committee that has a village development committees and the chiefs agents working together. On a monthly basis, they come together to look at the data. This data is looked at how many women are pregnant, how many have gone to the facility. And that is harmonized with the one of the facility and say, okay, this is what came for antenatal. Who is missing? It's for the chief's agent to now track this woman and find out why she's not come there. So that is the accountability mechanism that we've set up. And we have seen that it's worked. I've heard about it in Cross River and other things. So that is part of the NPHCDA SEMCHIC program, learning from what we have done in polio, learning from what we have done also with immunization. A little bit about quality of care and services. So we have expanded midwife scheme. We had a midwife scheme before, and now we are talking about the expanded midwife scheme, and then also basic midwife scheme. We have some of our states, they have schools, but they are turning out only 50, and they need more than that. So what do? Do we take the retired midwives? Do we take those who have come out of school? So it's a mixed bag for us and what we are doing. But then it's from school to practice. They come out of school, and they're right in there. And they'll say they have been trained. So as part of our program for quality is to make sure that they have mentorship, clinical mentorship, to make sure that they are doing the right thing for the woman, to make them come back. It's a tall order. It's an order for all of us that working together, we have to get things moving. And I'm happy to see that a lot of programs are coming up. But let's not harmonize, because most of us, we have our data, and next thing we are hearing it in Geneva, we're not hearing it here. Let's share these experiences, not only here. Let's go to the community dialogues. We have community dialogues. Let's go down there and dialogue with this woman and know what the issues are around maternal health. Data is important for us, and using data for action is what we are doing. We have a strategic plan, we have targets, and whatever we do, just have that strategic plan, and it goes to the state, and that is where it stops. Money is approved, but not released, and that is the issue. But thank God for the Basic Healthcare Provision Fund that provides at least 45% of that through the NPHCDA gateway to the state, right to the facility. They get this money on a quarterly basis, about 300,000 on a quarterly basis, and that is for the commodities. Working with the WDC, they're able to use it for commodities, for hiring extra hands, and also to make sure that they have, the tools. And if they have outreaches, that they also do that. So I believe that this government, and for us at NPHCDA, we are concerned, and we are happy that this conversation is going on, and we want to see it go further within our homes and within the household, that one woman matters to us. It's not only about here, but I will have to support government to deliver. Government cannot do it alone. Health is on the concurrent list, and that means we have a responsibility at national, have a responsibility at the state, LGA, community, even at your doorstep. When you go home today, call your village, call your ward development committee. Do you have one? You want to be part of it. You link up from your app. I'm sure they will link up with you to see what you can do, supporting government to ensure that we don't have any woman anymore dying from a preventable cause. I think I've spoken enough. I don't know. I'm just talking from what we know, but this is a summary of what we have here, that the issues around maternal health is a problem. Nigeria has not done well. Other countries around us have done much better. And one of the things they've done is to make sure that they strengthen the coordinating mechanism, make sure that funding goes down, and that the community is part of their health. They make decisions and they hold people accountable. Sorry, somebody talked about legislation. There's one ongoing now about the verbal autopsy at the community level. If a woman dies at the community, why did she die? And that is transmitted to the WDC, and there is, an audit. And if this is, done and somebody is found culpable, I think based on if it's a civil servant, they will apply the civil service rule. But within the community, they also have, how they take care of these things. Everybody will be held accountable for what they do. And the bill is supposed to come, is be a support, Rotary supporting it with SOGON, and I think pharmacists and the Federal Ministry of Health and NPHCDA and other partners working together to have this bill come out. So it's a good thing, and it's a future for us here in the country that we are talking about women and we're talking about children. Thank you very much.